I'm going to talk a little bit today about spinal cord stimulators for complex regional pain syndrome and why they work and why we use them. A lot of times when I present the idea of a spinal cord stimulator to my patients, they're kind of taken aback. Especially if they haven't heard of this technology, they think you're going to put wires in my back and you're going to implant a generator, and it sounds like a very foreign sort of concept. But actually, there's a long history of using electricity to treat pain. And the field is called electroanalgesia, which is the control of pain using electricity. So way back 5,000 years ago, the Egyptians knew about the electric catfish, Melepterus electricus. And they used to place these catfish that had electric shocks, just like an electric eel does, on joints that are arthritic to get pain relief. Hippocrates described the use of the electric torpedo fish back in 420 BC. And the Romans also knew about the torpedo fish and used that for pain relief. And it's kind of interesting. Scribonius Largus, who was a Roman physician, this is 42 AD, so 2,000 years ago. It's kind of an interesting quote. I'm sure glad it was preserved. For any type of gout, a live black torpedo should, when the pain begins, be placed under the feet. The patient must stand on a moist shore washed by the sea, and he should stay like this until his whole foot and leg up to the knee is numb. This takes away present pain and prevents pain from coming on if it has not already arisen. So what's interesting to me about this quote is that the Romans understood, maybe not technically why, but if you stand in water, it's a good conductor. And also it's interesting that we find a very similar phenomena, that when you have relief from electrostimulation, it can last even after the electricity is turned off. So people that have a stimulator may have it on for many hours. When they turn it off, the relief doesn't always go away. And it's interesting this was observed 2,000 years ago. They also used these fish for headaches. It's interesting, another application of spinal cord stimulation, actually peripheral nerve stimulation, is not putting a fish on the back of the head any longer, but implanting electrodes and having an implanted generator, and we get relief of occipital neuralgia and other types of headaches. So there was a lot of advances in electricity and magnetism over the next many hundreds of years. Classic experiment by Benjamin Franklin, where he flew his kite in a lightning storm. This conducted electricity down the string to the key, and the key was connected to what's called a Leyden jar, a primitive battery, demonstrating that lightning was electricity and preserving the charge. So in these days, electricity was called the subtle fluid. Back then, the scientists didn't really understand atomic theory. They didn't know about flow of electrons, and electricity seemed to behave like a fluid that they couldn't really get a grip on, but this explained a lot of phenomena about electricity. This is a Leyden jar, similar to what Benjamin Franklin used, and they actually would shock people with this to try to get relief. A lot of medical applications were found over the next several centuries, and in 1840 there was actually an electrical therapy department at Guy's Hospital in England. William Erb commented, "At the present time we possess in the electric current one of the most certain and brilliant remedies for neuralgia, although we must admit that much progress has not been made in our knowledge concerning its mode of action in these forms of disease." So I hope to enlighten you a little bit about what present-day thinking is on the mechanisms of why electricity works to help with neuropathic pain and CRPS. Just mentioned there was also, of course, a lot of electroquackery. So the radioelectric hairbrush was supposed to treat headaches, hair neuralgia, and hair growth. Needless to say, this didn't work, or we'd see a lot of people using these all the time, myself included. So electroacupuncture started in 1816. This is very interesting that the Europeans knew of acupuncture, which was used by the Chinese for thousands of years. In 1816, some of the scientists thought to attach electric currents to acupuncture needles and actually got an improved effect. And even today, some acupuncturists do electroacupuncture. They hook up electricity to some of their acupuncture needles. It wasn't long after that that they found that moistened electrodes on the skin could also work to get a similar effect. Electroanesthesia was used for over the next century, and the first spinal cord stimulator implant was done by Dr. Sheely in 1967. So we're talking about 50 years ago, the first spinal cord stimulator was implanted. So the basic concept is you use a low level of current to sort of block the impulses or change another feeling for pain and other symptoms in CRPS. One of the theories that's been around for, again, about 50 years is that of Wall and Melzack. So this is kind of pivotal in pain management, that electricity can block impulses. And the way that they hypothesized it works was what they called gate theory. So in gate theory, the electricity blocks the A beta fibers, which are not typically involved in the perception of pain. But when these are stimulated, they close the gate or block transmission of impulses along the A delta and C fibers, which do transmit pain signals. So the signal that ends up going to the brain is diminished because of the stimulation of the A beta fibers, closing the gate and closing down some of the transmission along the A delta and C fibers. So that's gate theory, and that's one of the theories of why spinal cord stimulation works. Okay, I'm just going to go through some of the other theories of why spinal cord stimulation works. So we talked about gate theory already, Wall and Melzack. That's where stimulating large fibers decreases transmission or closes a gate on other pain fibers. And there's also enhanced inhibitory descending signals. So your brain is always having signals come up from the periphery and come down to modulate. There's constant modulation going on in the central nervous system. The reason that some of you have been sitting here all day and you normally would be having some pain transmitted from sitting for so long, I know I would be feeling it, but, or you put on a pair of tight shoes and initially they really hurt, but over time it kind of goes away. And part of the reason for that is inhibitory signals. So you're constantly getting a modulation of the signals. So part of it is your brain saying, okay, I'm flooded with enough of those pain signals. Let's send down some signals to sort of quell that response so that we can go on with life. So that's one of the effects of stimulation, is enhancing the inhibitory descending signals, the signals that come down from the brain. There's actually neurochemical changes that take place in the spinal cord associated with spinal cord stimulation. So all the activity between neurons is, yes, it's electrical, but the way the electricity and signals and interactions is modulated is all chemical. Spinal cord stimulation has been found to actually alter the chemistry in the spinal cord, particularly the dorsal horn of the spinal cord. So the neurochemical changes include increases in certain substances like GABA, substance P, 5-hydroxytryptamine, adenosine, that tend to, increases in those chemicals tend to decrease pain. Things like glutamate and aspartate are responsible for pain signals, and those chemicals are actually decreased. So aside from neurochemical changes, we also have a decrease in sympathetic efferent activity. What that means is that you decrease the amount of sympathetic output. So the sympathetic nervous system is responsible for the fight and flight response. It's part of what's called the autonomic nervous system. You can't really control it consciously. It happens automatically. And the sympathetics are responsible for a variety of things, but one of their main functions is to control the way blood vessels function, either dilating, opening up to allow more flow, or closing down and constricting. In complex regional pain syndrome, a lot of people have impaired circulation. They have diminished circulation to an extremity. That's why we do sympathetic blocks, to block the sympathetics and open up those blood vessels. So spinal cord stimulation actually has an effect on the sympathetics, and by blocking the output of the sympathetics, they allow dilation of blood vessels to help treat some of the coldness, some of the cyanosis or deepened coloration in reflex sympathetic dystrophy, or CRPS. We also get attenuation of wide dynamic range neuron response in the dorsal horns. So translate this to common language. So it diminishes sort of the way that the spinal cord amplifies signals. So if you think about pain, pain's actually very adaptive. We need pain. If you injure yourself, you need to know it. So pain is a good thing. Now, when it spins out of control, like it does in neuropathic pain and diseases such as complex regional pain syndrome, it's not a good thing. But pain itself is good. If you stab yourself with a red-hot poker, I don't recommend it, but if you were, you would feel initially pain where that happens. Then after a little bit of time, what we call the receptive field would kind of broaden, and your entire hand would hurt. Pretty soon you get to the point where you even move your wrist or even your arm, and it hurts. So this is adaptive. This stops you from moving something and using something and gives it the opportunity to heal. So amplification of the signal is a normal part of the pain response. Part of the way that's done is on a spinal cord level. The wide dynamic range neurons can change. They can respond to a variety of stimuli, to a variety of intensity, depending on what input they're given. So they're responsible for part of the amplification of signals of pain that, again, is adaptive. The problem with the amplification of signals is it's supposed to go away as you heal. In neuropathic pain or abnormal pain syndromes such as CRPS, unfortunately, that doesn't happen. You have a constant amplification and increase in signals even though the inciting event may no longer be present and healing may have already taken place. Okay, so complicated slide, a lot of things, and I'm just going to go through them just briefly so we see where spinal cord stimulation works. So again, this is the red-hot poker. Normally, the signal goes up through the A delta and C fibers and gets up to the cortex and also to deeper areas of the brain. And then there's inhibitory output from the brain to diminish the signals. So when we use spinal cord stimulation, we block pain and block symptoms of CRPS at several different sites in the nervous system. By gate theory, in the dorsal horn, by stimulating the A beta neurons, you decrease the transmission in the A delta and C fibers. You get enhancement of the inhibitory signals. Those are the signals that come down and try to quell pain sensations. You get the chemical changes we discussed also in the spinal cord. You get the decreased sympathetic outflow, so you can allow for vasodilation to get improved circulation to extremities. And you get a decrease in the wide dynamic range neuron response. You decrease the amplifiers of pain in the spinal cord. So when do we use spinal cord stimulation? We use it for a variety of neuropathic pain syndromes, particularly complex regional pain syndrome, as everyone knows, now formerly known as a reflex sympathetic dystrophy. We use it for other peripheral neuralgias. We also use it most commonly for failed back surgery syndrome, which is actually a combination of mechanical and neuropathic pain. Some examples of individuals afflicted with CRPS. Anybody here that's here today is very aware what this disease can do. So spinal cord stimulation for CRPS, I call it better living through electricity. So what can it do? It can decrease pain and allodynia. Allodynia is feeling pain even to light touch. Decreases circulatory impairment and cyanosis. That's from the sympathetic blockade. Decreasing swelling due to circulatory effects. This allows for physical therapy because you really reduced pain. You're able to do the modalities that seem to help, desensitization, maintaining range of motion. And it can be used early in the course of treatment if physical therapy, anti-epileptic drugs, sympathetic blocks, and other modalities, ketamine, aren't adequately effective. So one important note about spinal cord stimulation, and this is one of the concepts I make sure my patients understand when I'm recommending stimulation, is this is one of the few surgeries in medicine where you get to try it out before you get your surgery. You get to do a test drive. Most surgeries, if you're going to have your back fused, you don't know until 6 months later if it's going to help you or not. If you're having your hip replaced, you're waiting several months to know if it works or not. With spinal cord stimulation, we put in trial leads, and you get to try it for a week and see if you like it. You get to manipulate the controls, and you see if it helps, and you see if you like it. If it does, no matter what, after about a week, we take out those trial leads, and we implant, and we wait a few weeks and then implant a permanent stimulator. But you get to try it and see what it's like before you buy, kind of like a test drive. So this is my test drive slide. Not that I would buy that even if I test drove it, but. All right, this is what the trial looks like. This would be for lower extremity CRPS. So the leads are going into the epidural space. They're outside of the spinal fluid. They come out through the skin, because we just put them in through needles. They come out to the side, and you wear this around your waist, and you have a little generator box that you carry around with you for a week and manipulate controls on. The advantage of electrical stimulation over other modalities used to treat complex regional pain syndrome, one of the most important ones, it can be highly effective, and it's a non-medication pain modality. A lot of patients are actually able to decrease the amount of medications they're on if they have a spinal cord stimulator that works for them. You get to do the test drive before surgical implant. It's a removable device. So if the disease stops progressing, if medications and other treatments are working, if we're able to get it under control and you haven't used it for a year or something, we just take it out. Or if for any other reason they need to do surgery in that part of your spine, it's very simple to remove. It can be useful early in CRPS if other modalities aren't effective, and dramatic results can be seen very quickly after implantation. So I'm not going to go through these studies. There are hundreds of studies that show the efficacy of spinal cord stimulation. In this one, this was spinal cord stimulation with physical therapy versus just physical therapy. And you can see we had improvement of 63% of patients that had spinal cord stimulation in conjunction with physical therapy versus 9% if it was only physical therapy. This is another study where pain scores after a year had gone from 10 centimeters to 1.7 centimeters. And at about 3 years, about 70% of these patients had returned to work. The Kumar study in 2013 is important because it showed that spinal cord stimulation, these are expensive devices, but it's actually cost effective. And in the current world of insurance and healthcare provision, having something that can be proven to be cost effective means insurance companies will approve it because in the long run, it's cost effective. So what I think of the future of spinal cord stimulation, I think there's going to be continued development as far as technical aspects. I mean, this is a very low complication procedure, but there is rare infection. We do get lead migration now and then, and new techniques as far as suturing and anchors are being developed. There's going to probably be less invasive stimulation methods developed for placement of stimulators. And there's certain to be further technological advances. So the stimulators that were around 15 years ago were huge and had very little capability. The ones that were around 10 years ago were, the next generation, were incredibly better. The ones that were around 5 years ago, when they came out, they were just amazing. They were smaller, they had more contacts. The ones that are out now are even better. This is technology, it's moving quickly, and as time goes on, this technology just keeps improving. The types of stimulation that are currently available, conventional dorsal column stimulation is what I described, where people sort of trade their pain and their, a lot of times, vascular insufficiency for a buzzing or a throbbing sensation. So they actually feel the stimulation. but there's actually just in the last year to a few months to future this is what's going on in stimulation. High-frequency stimulator just got released in this country where you don't actually feel stimulation, but it still has the same effect. The other nice thing about high frequency is many patients with neuropathic pain, due to plasticity of the central nervous system, tend to lose the effect. So it's very unfortunate, but a lot of patients with CRPS, after a few years of having stimulation, say, I feel it, but it's just not working anymore. So one of the techniques to get around that is using a high-frequency stimulator. Dorsal root ganglion stimulation, I think, just got released, within the last month in this country. And we're looking at burst stimulation, another modality of stimulation that's coming out. So this is the future and actually the present and immediate future. So we've come a long way since ancient people used electric fish to put on the area that hurt. We have the development of theories of electricity, early batteries. Wall and Melzack developed the TENS unit. I think most people are familiar with that, transcutaneous electric nerve stimulators, based on the gate theory, to where we are now, where we have a little implantable generator, sort of a pacemaker for pain, that goes along the spinal cord and the epidural space to help treat neuropathic pain.